All right, so I hope everybody enjoyed their trip to UP this weekend, and I certainly hope that you found a nice job for the summer. Maybe even went to the job fair. That'd be cool too. All right, so welcome back. It's week 11. Won't be much longer. Hope everybody got good information at the job fair today and have lined up something or are in the midst of lining something up for next summer. Good luck. So today we're going to talk about antihistamines, decongestants, cough medicines, including expectorants. And then we'll talk about asthma and emphysema and bronchodilators, the beta agonists, the anticholinergics, the xanthines. Then we'll talk about leukotriene antagonists. And finally, that thing that I sort of forgot to tell you about last week when it was important to do so, the corticosteroids. So to begin with, remember that in adults we're able to breathe through our nose and through our mouth, and all that air gets mixed together in the pharynx and then goes down to the larynx. And then the air passes through the trachea and then into the right main stem bronchus, the left main stem bronchus, and then of course it gets distributed through the bronchi and down to the alveoli, which are the working units of the lung. So this is not a very well drawn depiction. I think it's important to know that the right main stem bronchus actually follows more of a track like this, where it sort of has a straight down effect. It's a straight shot down to the base of the lung. And the reason that's important is that if you aspirate on food or water or drink or whatever, that aspirate goes right down to the right base. And so typically when we see aspiration pneumonias, they are right basilar pneumonias. Okay, so again, the alveoli are the working units, and what the alveoli do is they exchange air. So at the very basic level, the oxygen comes from the alveoli across this semi-permeable membrane and gets diffused into the blood, where it's picked up by the red blood cells. And then, of course, the CO2 comes out of the blood and crosses across this semi-permeable membrane and then gets exchanged as air in the alveolus here. Remember, the thing that holds the alveolus open, and the entire lung as a matter of fact, is this surfactant stuff. So surfactant is kind of, it's like a soapy liquid that's just sticky enough to make things stick to one another, and so it's the pleura that stick to one another and hold the lung up. Now, in order to understand antihistamines and such, we need to understand the process of inflammation. So remember, inflammation is that initial step that keeps the body healthy. It gets rid of all the bad invaders in the body, shall we say. So what happens is, if there's cellular injury or some pathogenic invasion, the body gets activated, the immune system gets activated through this plasma system. So complement, fibrin, kinin, and all these other chemicals are released that produce a whole array of things in the body. The other thing that happens is that mast cells show up, and mast cells then degranulate, and all of these granules come out, and histamine is released. So histamine is one of those things that causes badness if you have allergies. What are the things that happen? Well, first is vasodilation. So you get vasodilation and congestion in the vasculature of the involved part. So that could be in the lungs, it could be in the head and neck, etc. There's also this vascular permeability where the fluids can leak out into the interstitial space. That's edema. Then there's cellular infiltration, where these macrophages come out of the vessel wall and are in the interstitial space then. There's thrombosis that can happen, so clot can form in there. And then, of course, there's also stimulation of the nerve endings, and pain can result. Now, that's not always something that happens, but certainly for things like pleurisy, you can have pain from that. Typically, the kind of pain that we're talking about with pleurisy is different than the pain that you have with other inflammatory processes. So allergic reactions are characterized then by constriction of vascular smooth muscle. There's also vasodilation that happens. It sounds a little counterintuitive, but in addition to this vascular smooth muscle, there's also constriction of bronchi, the bronchial smooth muscle. There's an increase in body secretions, and then there's an increase in this capillary permeability and edema formation. So those are all the things that we would like to stop in the allergic reaction process. Antihistamines are one of the ways that we do that. Now, there are several subclasses, and these medicines all have different sedative and anticholinergic effects, as you can see in this table to the right. So what are the indications? Well, allergic rhinitis, allergic reactions. We can also use these for motion sickness, Parkinson's symptoms, and vertigo. Adverse effects, as I mentioned, sedation is a big adverse effect. For those of you who've taken Benadryl before, you know that Benadryl is very sedating. You can see that it's the highest of all of the antihistamines in terms of sedation. There are also anticholinergic effects, and believe me, I was probably a nurse for 2 years before I knew what that meant. Anticholinergic effects. That's something you should know. So I want you to learn what anticholinergic effects are. They include dry mouth, visual changes, again from the dryness, urinary retention, constipation, also CNS agitation is another one that is common. So these are the anticholinergic effects, and it's important that you know them. It's also important to know that because of the urinary retention, we have to use this cautiously in men over 50. So I know I said elderly men here. It's more than that. It's men as young as 50 who have to be careful with the use of these medicines because of that prostate issue. So there's 2 antihistamines for you to know. Usually we want you to learn one medicine from each class, but here I think you should know both of these. The first is Benadryl, which has an intermediate antihistamine activity, but it's the most sedating, and it has a very high anticholinergic effect. It's important to know also that we don't give Benadryl or diphenhydramine in liver failure because it is metabolized exclusively by the liver, and so we have to be very careful of that in patients with liver failure. Loratadine or Claritin, many of you probably take. The reason you take it is that it's a very good antihistamine that has very little or no sedation and no or little anticholinergic effect. So the things that are useful about Benadryl are the and the reason that we use it is really because of its sedating effect. It's also a decent antihistamine, but if you really want good antihistamine coverage and you don't want to be sedated, then Claritin is a much better choice. And there are others too, but that's the one that we're going to have you learn about. So decongestants. Now, first of all, we have to understand what congestion is, and for our purposes, we're going to use we're going to refer to congestion as excess nasal secretions and swollen nasal mucosa. All right, that's what we're going to discuss with congestion here. So there are 3 subclasses of decongestants: the sympathomimetics or the adrenergics, and we'll talk about those, the anticholinergics, and then the corticosteroids. So Sudafed or pseudoephedrine is an alpha-1 agonist, and we learned the first week or 2 that alpha agonists increase the blood pressure by vasoconstriction, right? So that's exactly what happens with Sudafed. You take Sudafed, and all those swollen, dilated arterioles in your sinuses constrict, and that relieves the edema and the swelling in your nasal passages. You get very good relief from that vasoconstriction, and you feel really good. So those of you who have used Afrin nasal spray, you probably have had that experience of being able to breathe not one bit, and then you spray the Afrin nasal spray in there, and within a minute or two, it's like you never had a cold. It's really a remarkable thing. Now, the downside of that is that it's a highly addictive medicine, physiologically addictive, that is. And what that means is that after you've used it for 2 or 3 days, your body's sort of dependent on it in order to keep your nasal passages open. And so you don't want to use that medicine for more than a day or two. Okay, so the adverse effects of pseudoephedrine and other sympathomimetics include hypertension. Makes sense, right? That's the way it works. But there have also been some descriptions of stroke in the literature, particularly among women. And the first paper was published in 2003 that demonstrated that discussed 22 women who had had strokes when taking sympathomimetics. So this was about the same time that we started to reevaluate whether we really wanted kids and women, or anybody for that matter, to be using cold medicines that could potentially be harmful. Now the numbers are very small, right? I mean, there was 22 people in among how many hundreds of thousands or millions of people who've taken these medicines. But the number is not zero. And that's the important thing to know, that you certainly can have bad outcomes from taking seemingly harmless medicines. So why the picture of the Smurf? Well, if any of you have seen Breaking Bad, you know that there was one part early on in the series where they were going to try to make crystal meth with pseudoephedrine. So they got a bunch of Smurfs together. These are guys who go into drugstores and steal pseudoephedrine. And it turns out that they just didn't have the ability to get the volume of pseudoephedrine with that method that they needed, so they had to go to another method. But the take-home message is that when you go to the drugstore now, you can't get the good stuff. You can't get the pseudoephedrine on the shelf. You have to ask for it. It's behind the counter. So then they make you, give your fingerprints and give a blood specimen. Well, it's not that bad, but you do have to sign something and show them some ID so that you can get pseudoephedrine. What they have out on the shelves is another sympathomimetic, but not nearly as powerful or as effective, and that is phenylephrine. But the pseudoephedrine or ephedrine is the better stuff in terms of symptom relief. Okay, so let's talk about cough. Well, you might be surprised to know that the top 3 reasons for cough, in fact representing 90% of all cough, are postnasal drip, asthma, and GERD. 90% of all coughs are from one or more of those problems. Other causes include respiratory infection, ACE inhibitors, like we talked about before, remember, because of the bradykinin, chronic bronchitis, lung cancer. So there are more serious considerations for cough, but 90% of the time it's due to postnasal drip or asthma or GERD. So that makes you wonder, should we even really treat cough? And there are some people who say, no, we really shouldn't treat cough. It's a good thing. Our body has us cough for a reason. And if it's not, if there's no other danger in coughing, then maybe we shouldn't treat cough. Well, it's interesting that even when we try and treat cough, we're not very good at it. It turns out that codeine or other opiates and dextromethorphan, which is kind of a cousin. And the dextromethorphan is the stuff that you find in Delsum or Robitussin cough syrup. By the way, if you're going to get cough syrup, Delsum is really delicious. It's very good as compared to that other stuff, that Robitussin stuff. Boy, I can't even gag that down. But the take-home message here is that the codeine and dextromethorphan are the things that we prescribe for cough, and they're really not good. I mean, no matter what, we give people cough medicine because we want to do something to help them to feel better, but the reality is that there's not much that we can do. And in fact, we might find that giving them something to prevent their postnasal drip, something like a decongestant, may actually treat their cough more effectively than cough medicines do. Now, there is one cough medicine that actually is helpful, but you've probably never heard of it before, and that's Tessalon pearls. They're probably the best ones available, and what they do is, or what it does, is it actually anesthetizes the cough receptors. So of all the antitussives out there, Tessalon pearls is probably the best. Moving on now to expectorants. Expectorants essentially loosen the mucus and facilitate the ability to cough that mucus up and get it out. So again, cough is a good thing, and if we can give expectorants that pull that together and get it out of your chest, that's probably a good thing. So guaifenesin, or Mucinex, but again the generic name is guaifenesin, is the most common expectorant that we have on the market. It's generally very well tolerated. There's essentially no interactions with using it, so it's very safe. All right, so now let's talk about pulmonary problems specifically. Starting with asthma. Here's a little pictorial representation of what happens with asthma. You know, it is an allergic thing, so there is degranulation of mast cells that cause this inflammatory process to happen. There's excess mucus production. There's smooth muscle constriction in the bronchioles. You may actually have some mucus plugging, in fact. The mucus becomes stuck in that airway, and it's hard to get that out. And then you may also have some hyperinflation of alveoli as a result of that kind of mucus plugging and restriction of flow. So here's another representation of what happens. Remember, there's this antigen that enters the airway, and that comes in here and produces the allergic response, which includes epithelial injury and mast cell degranulation and the release of all that other stuff, IL-4, IL-5. The B cells get involved. The helper T cells get involved. The eosinophils are the allergic response white cells. And then we also have mucus secretion that we talked about, and vascular leaking of fluid, and then of course the smooth muscle constriction that happens in the bronchial smooth muscle. So what drugs do we use to treat asthma? Well, there's a whole bunch. There's leukotriene receptor antagonists, there's mast cell stabilizers, corticosteroids. We do use anticholinergics, but not as much as we do in COPD. We'll talk about them more later. And then we use long-acting beta-2 agonists and also short-acting ones, but more, again, in the long-term control, we use the long-acting beta-2 agonists. Theophylline we used to use all the time. So, 20 years ago, 25 years ago, theophylline was the biggest asthma drug on the market. Today, that's no longer the case. It's a much harder drug to use. We have to get levels, and it's just a pain in the neck, and doesn't work as well as some of these other ones do. So those are the meds that we use for long-term control. In the short term, in the rescue, if you are out playing football. I remember when I was in midget football, I was probably, 8 or 9 or so. There was a kid on our team who was asthmatic, and periodically he had to use an inhaler, and it was like a big deal. Every time he had to use his inhaler, the whole team stopped. Everybody checked it out because nobody else had asthma, so it was like a really unique thing to see this kid use an inhaler. You know, it's something that we sort of take for granted now. But I'll tell you, when you're 8 or 9, there's nothing more fascinating than seeing somebody take a breath from an inhaler. So we use IV corticosteroids, IV, not inhaled, but IV corticosteroids for rescue, and then of course the short-acting beta agonists. So what are the things that happen in asthma? Well, we have all these allergens in the environment: dust, wool, feathered pillows, pollen, etc., and those get inhaled into the lungs, and then there's histamine release, and all of these other resulting things that happen, the spasms of the smooth bronchial muscle, etc. So all that stuff happens and causes the reactive airway disease that we call asthma. So the ways that we can fix it are leukotriene antagonists that block the release of these leukotrienes in the lungs, and that inflammation causes an increase in leukotrienes, and that substance constitutes the slow reacting substance of anaphylaxis, or SRSA. Okay, so if we block the leukotrienes, then that blocks this SRSA, which is one of the things that causes smooth muscle spasm. Theophylline, as I said, we don't use it very much anymore, but it is a drug that is useful in allergy sometimes. We have mast cell stabilizers that inhibit the release of histamine from those mast cells, prevent that degranulation. Sympathetic agonists like the beta-2 receptor agonists, and then corticosteroids as well. So the other thing that we should talk about is COPD. So we talked about asthma, and when I was in school, for some reason, we learned that asthma is one of the COPDs. I hope you're not learning that, because it's not really the case. Asthma is more of a reactive airway disease, and COPD is not. COPD is really two conditions called chronic bronchitis or emphysema. Those are the two conditions that constitute COPD. And essentially what happens in chronic bronchitis is, again, this inflammation and thickening of the mucous membrane here. And there's accumulation of mucus from these submucosal glands. And then that results very often in mucus plugging. And of course this hyperinflation of the alveoli. Again, similar to asthma, but at a whole different level. And then the other kind of chronic lung disease, or COPD, is emphysema. And emphysema is really marked by destruction of these alveoli. And what happens is they get hyperinflated, and they get thin-walled, and these holes in the alveoli can lead to bleb formation. And these blebs essentially are just big pockets of air that are held in by some sort of a tissue wall. And so that obviously doesn't allow for good gas exchange. There's plenty of air in your lungs. In fact, that's one of the problems with COPD. It's hyperinflated. There's tons of air in the lungs. You can't get rid of it, though. And there's not good gas exchange as a result in emphysema. Okay? So again, COPD, chronic bronchitis and emphysema. And then asthma is not one of the COPDs. It's a reactive airway disease. Here's another representation of what happens in COPD. In a normal lung, we have the air coming back down into the alveolus, and even if there's some mucus in here, the air can get back out. But with COPD, there's this bronchial wall collapse. There may be some muscular tension here. There may be some mucus plugging that occurs, and what that does is it further restricts that airflow and keeps the air trapped. This is an air trapping phenomenon. So that's COPD. So how do we treat it? Well, beta-2 agonists are a big part of treating COPD. What they do is when we activate the beta-2 receptors, which predominantly are in the lungs, right, that causes bronchodilation. So we use beta-2 agonists like albuterol or Ceravent. Prevental or albuterol being the short-acting, which has an immediate onset and a duration of 3 or 4 hours. And then Ceravent or salmeterol is the long-acting beta agonist, and it has an onset of 30 to 48 minutes. I love that. 30 to 48, not 47, not 50, 48. And then in COPD, it can actually have a longer onset of action, up to 2 hours. It lasts about 12 hours, and again, what beta-2 agonists do is they cause bronchodilation by direct activation of the beta-2 receptors. So, although they're classified as beta-2 agonists, they may also have some beta-1 effect. So you may see people who are getting these have a little tachycardia, all right? They may get a little hypertensive as well. And those are just side effects that we have to live with because we don't have much of a choice otherwise. But they're highly beta-2 selective for most of our patients. The only major interaction is with the MAO inhibitors because there can be an increased risk for hypertension with them. The important thing to remember, though, is that beta-2 agonists, the long-acting beta-2 agonists like Ceravent, are not for rescue. You can't use these to help somebody who's having an acute attack. That's an important thing to know. All right? And you should only use it twice a day. In this case, you should only use it twice a day or as directed. So how do we give some of these things? Well, there's 2 ways. The most common way is the metered dose inhaler, or the MDI. And so you've seen these before. You have a little plastic thing that you put the canister in, and then the canister touches this tube here that delivers the aerosolized mist from the mouthpiece. So you put this mouthpiece part into your mouth, and then while you squeeze the MDI, you inhale, and then that drug gets delivered to your lungs. Now, one of the problems with that method, particularly when we're talking about corticosteroids, is that a lot of that medicine ends up on your tongue and on the skin in your mouth, and that, or the epithelium in your mouth. And that's not what we're looking for, right? We want that material to get into the lungs. So the other way that we'll do it, I'll talk to you about in just a second, is with a spacer. But the MDI is the most common way of delivering these drugs. Okay? The other way to do it, the way we do it in the hospital, is with this nebulizer. Some patients call it their peace pipe, and essentially this little canister here gets filled with the drug that you want to deliver, and then we hook it up to oxygen, and the oxygen flows into it, mixes with this water, and then gets aerosolized in this component, and then this is the mouthpiece, and you just breathe through this. And this is a better way to deliver the drug than the metered dose inhaler, but it's less convenient too, right? It's convenient if you're in the hospital, but you can't just carry this in your pocket. So if we deliver these to kids, then we put a face mask on them, and then they can breathe this aerosolized stuff through the face mask. But for adults, we just use this little peace pipe mechanism. All right, now remember I told you about using inhalers, and how if you put this inhaler in and inhale it while you squeeze while you inject the drug, you may end up with a lot more of that on your tongue than anywhere else in your lungs. So they have this other device called a spacer, and what you do is you take the inhaler and you put it into the spacer. Then you squeeze the drug. It gets aerosolized into the spacer, and then you inhale through that. So this prevents you from getting the drug on your tongue or in your mouth much, much better. So we typically recommend spacers for everyone, and in the emergency department we use spacers quite a bit. They need their own spacer, right? You can't share spacers, so they need to get a spacer, and this is particularly good for people when they're first learning. As they get better with it, then they will learn to inhale it without squirting it all over their mouth. Okay? Anticholinergics then. So Atrovent is the anticholinergic that we're most likely to use. That's a trade name, but ipratropium is the generic name. Ipratropium. These drugs, this drug is used so often in COPD with the beta agonists that they've actually come up with these combination devices. So the MDI comes in something called Combivent, and so it has a certain amount of Atrovent with the beta agonist, which is Proventil. Okay, so that's what Combivent is, and that's the MDI formulation. Duoneb is the formulation that we dump into the nebulizer and give that way. So the mechanism of action here is that it activates the acetylcholine receptors, which essentially is the parasympathetic nervous system, right? And that prevents bronchoconstriction, and it also reduces secretions, which is another important way that it works, particularly in chronic bronchitis. So it's indicated for chronic bronchitis and emphysema. I always learned that we don't really use these in asthma, and the research that I did says that we can use them in moderate to severe asthma exacerbations, but it turns out that once the patient is hospitalized, there's no benefit to using anticholinergics for asthma, in the hospital. So we just don't do that. It's of no benefit. It may be of benefit in moderate to severe asthma to keep them out of the hospital, but once they're in the hospital, then we sort of abandon the use of that. Now there are some contraindications, and a peanut allergy is one of them. So having a peanut allergy is an important thing to know about because it can cause anaphylaxis when you're using Atrovent. There's also caution to be exercised in using it with acute narrow angle glaucoma and BPH. Again, these are things that are worsened by anticholinergics. Okay? The most common side effects that we see are the anticholinergic effects, and those are dry mouth, palpitations, GI symptoms, urinary retention, CNS agitation. Those are the things that we see typically with these with Atrovent. Although, again, generally a pretty well tolerated medicine. Maybe makes some people a little jittery when they get it, particularly in the nebulizer, but generally pretty well tolerated. Now we also have these xanthine derivatives, which we really don't use anymore because they're just hard to use. The way they work, and by the way, by xanthine derivatives, we can really just say theophylline. All right. So the way theophylline works is it's taken into the body, whether by pill or by IV. Actually, aminophylline is the IV form, but theophylline is taken orally, and then when it gets into your body, it gets converted to caffeine. So that's the benefit, and that's the mechanism of action that works in the body. The secondary benefit of giving caffeine is that it increases respiratory drive in the medulla oblongata. Remember that? It also causes bronchodilation, and the way that works is by increasing cyclic AMP. And there's also a quaternary benefit of positive inotropy, which is the squeeze of the heart. And the downside is that you get a faster heart rate with it at higher doses. So again, we don't use it very often. There's a lot of interactions, including oral contraceptives. Caffeine is another additive effect. And we have to monitor blood levels for this medicine. So for that reason, in addition to the fact that we have better medicines now, theophylline has really fallen out of favor. Leukotriene receptor antagonists like Singulair, these have a unique effect, and what they do is they block the inflammatory process on the white blood cells and the white blood cells that go out of the circulation and become macrophages in the lungs. And those things are active in asthma, as we talked about earlier. So these prevent bronchial smooth muscle contraction, they decrease mucus secretion, and they reduce vascular permeability, all those things that we talked about happening with the inflammatory process. So we can use Singulair, which is also known as Montelukast. Montelukast is the generic name. That's the one you should know. So we use this in adults and children if they're 12 or older. It also has an indication for allergic rhinitis. Adverse reactions, the biggest one is liver toxicity, so we have to monitor liver function tests on people. And the most common side effects are headache, nausea, and diarrhea. And then finally, the thing to know about this is if somebody's having trouble breathing or having an exacerbation of asthma, this is not a rescue drug. You can't take more and expect that it's going to help you. Okay? Finally, corticosteroids. So this is the thing that I'm embarrassed I forgot to tell you about last week. Remember that corticosteroids are ordinarily produced by the adrenal cortex. Corticosteroids have a direct anti-inflammatory effect, and when used with the beta-2 agonists, they may actually potentiate or increase the amount of effect from the beta-2 agonists. So we use corticosteroids in exacerbations of asthma because it calms down the immune system, the immune response, right? And by the way, that's not always a good thing, right? So you probably have learned, and if you haven't learned, I'm going to teach you, that we never use steroids with active infection because it's just a bad thing to do. We're treating the infection. We want the body to be stimulated to have a good immune response. Then we give corticosteroids, which has the opposite effect, right? So we never want to use corticosteroids in an acute infection. So I said never, but that's not really true because we often use corticosteroids in addition to antibiotics, and a prime example of that is in COPD problems. So you get an exacerbation of COPD. We also determine that you have a related or a superimposed infection like bronchitis, acute bronchitis. And what we have to do then is we have to treat both the inflammatory process, which is the COPD, and the infection. So we don't like to do it. We always feel a little weird doing it, but we often do it in cases like this, where we use corticosteroid with an antibiotic to treat an acute infection and the inflammatory response. So you should be a little curious and hesitant to when you see that combination together. It's right to be confused about that. But the reason that we do it, the reason that we use corticosteroids in an acute infection is because we have a need to treat both the infection and an underlying inflammatory process. Okay. Another example is if you get pink eye. What do they do when you get pink eye? Well, ordinarily you just leave it alone. It's, you feel lousy for a couple of days until it resolves. But if you go see your eye doctor, what they often do is they give you Tobradex, which is a antibiotic, and it's a corticosteroid, and so you feel better immediately, which is the reason to do it, right? But you get an antibiotic for that infection, even though it's probably viral. So that's another common time that we use both a corticosteroid and an antibiotic together. So back to the slide. The indications are exacerbations of asthma, bronchitis, and emphysema. We can use corticosteroids for chronic management of asthma. And what we use is an inhaled version. So the inhaled one that we use is Flovent. All right? Flovent, or others, there are many others actually on the market, are just inhaled corticosteroids that we like to think, and we hope, really stay in the lungs, so that it's really just treating that inflammatory process and not poisoning the or suppressing the adrenal glands. Okay? So adverse effects, well, for systemic steroids, like we use oral prednisone or IV solumedrol, which is methylprednisolone, again, another corticosteroid. So for those systemic steroids, the adverse effects are elevated white cell count. We know about hyperglycemia. We've talked about that already. You have an increased susceptibility to infection because we're calming down the immune response. That's part of how this works. Remember that with corticosteroid use, we get potential for hypokalemia. You can also have fluid retention. You can get insomnia, nervousness. You get a little agitation with it. You also get extraordinarily hungry when you get systemic steroids. You just want to eat everything in sight. And then in the long term, we worry about things like adrenal suppression. So if we have somebody on corticosteroids for a long period of time, more than a week or two, then we really need to wean that dose so that the adrenal glands get used to working on their own. So we have weaning parameters that we use for, or weaning doses that we use for corticosteroids all the time, and every provider has their own way of doing it. In fact, some of the drug companies have come up with their own ways too, and they sell these packs like a Medrol dose pack. The problem with a Medrol dose pack is that it's too short and not powerful enough to really be useful, but it does do the weaning thing for you. Okay? So inhaled steroids then, again, are useful for chronic management of asthma. The biggest side effect from those is a cough, dry mouth, and then these oral fungal infections. So this is the time that we really want to be careful using that inhaler, and make sure that when people use an inhaled corticosteroid, they're using a spacer. Again, when we put somebody on a steroid, we increase their susceptibility to infection, and particularly fungal infections. So one of the nursing considerations is to always monitor for fungal infections. And then, of course, we have to monitor blood sugars both in diabetics and in non-diabetics. And so when you're in the hospital at Hershey, for instance, or most hospitals, and you're put on steroids, you usually get some insulin coverage, even if you're not diabetic.